6, 5, 4, 3. Hi, thank you for being with us here today. We're going to talk a little bit about community Passmore, and I'm get to start us off. I'm going to go over some of the bigger principles in community engagement, and then I'm going to pass it off to my colleagues here who are going to give really wonderful examples. So I'm just going to start with some basics. So why do we do engagement? Why is that important in research? I think many of us already know many of the reasons why it's important to include patients and community members in research. Some of them are, one of the most important thing is that they give us context of the community or condition or the burden of illness, whatever it is that we're studying. They also help us to identify processes and procedures that might be too burdensome for other participants. They help us to make sure that our research outcomes are meaningful. And so that might be something that doesn't necessarily come to us as researchers. We might be thinking about outcomes that are really clinically based, but if they're not meaningful to patients, then they're not necessarily contributing to the quality of life. And so we really need to have the input of patients and community members to understand what research outcomes we should be working towards. They can help advocate and mobilize people for research participation and help disseminate results clearly to diverse communities. So, you know, as researchers, we're not necessarily the best at communicating to general populations. I know that I struggle with that a lot, and often people can help us with that kind of communication. More why. One of the biggest reasons why we need to engage with communities and patients in research is to include those populations that are experiencing health disparities in our research. And there's a few reasons for that. And these are the groups that NIH have defined as health disparity, populations experiencing health disparities. So racial ethnic minority groups, people with lower SES, underserved rural communities, sexual and gender minorities, and just as of last year, people with disabilities are also included in this list. And as we are working towards health equity, we can't do this without the engagement of those populations that are experiencing health disparities, for all the reasons that we mentioned already, but also because these are the populations whose voice has not been historically in research. Many of these populations are not represented in equal numbers in the scientific workforce, nor are they represented necessarily in research participation. So in other words, their voices aren't there unless we are specifically engaging with those voices, those people. Another important issue is this historical, political, and social context. So there is a history of research abuse for these same populations. So I think many of you probably recognize what looks, I guess, is the top right here is Tuskegee syphilis study, right? And then next to that is Henrietta Lacks, right, who gave her cells unwittingly to cancer research. Probably less well-known is the Guatemalan syphilis study, which is very much like Tuskegee, actually done also by the U.S. Public Health Service. So Tuskegee, a lot of people feel like, or think that the researchers gave syphilis to the people who participated in Tuskegee. They didn't. But the folks that did participate as research participants in the Guatemalan syphilis study were given syphilis. They were prisoners and prostitutes and other people in really marginalized situations. But it's not only immigrants or racial ethnic groups. We also have this picture down the bottom of the school building. It's a Ferndale School in Massachusetts in the 40s. Was a home for intellectually and developmentally disabled boys who were used in studies to understand the progression of ingesting radioactive material. So, and then I also have a picture of the Jewish chronic disease study, which was also about understanding the progress of disease with this population. And I could just keep talking and talking about, there's many of these. So we have a history, and that travels with us that we need to address when we go into these populations. And because so many people might, I don't know, so many people, but people might think that, Tuskegee happened in 1972, or ended in 1972, rather. And all these things happened before the Belmont Report, so they're not really important today. That's not the case. So I just wanted to include this chart, too, that was done by the Pew Research Center in 2021, where the majority of Black adults say medical research misconduct is just as likely to occur today as it was in the past. So this is not something that's gone away. This is something that's very present, and it impacts how we do our work. So who to engage? We can really engage anybody. Anybody whose lived experience or knowledge has some kind of bearing in how we do our work, and can give us that important insight into how we should create our studies. So patients, caregivers, clinicians, policymakers, and a little bit, Dr. King's going to talk to us about her research in healthcare settings, where it's critically important that if you're going to implement an intervention in people's workplaces, that you include them in their understanding how you're going to be able to do that. And how to engage. So there are several things here, and there are lots of different models out there about the different principles that go into engagement. And this one is sort of a simplified version, but I think it hits the big ones. And we can talk about that if I missed anything later on in the questions. I'm going to start with transparency. That really goes back to the issue about, we talked about a little bit earlier, with the research abuses that have happened in the past, right? It's critically important that people see our intentions and actions, and that they go together. Flexibility, we as researchers sit back in our offices and come up with really great ideas about how to do things in the real world, and then we get out there and find out that they don't work. So being able to be flexible and listening when community members or patients give us advice, to take it, even if it means a delay. Equity, also critically important, that we make sure that everybody is treated as equals in their contributions to the research, which also goes hand in hand with this idea of mutual respect. Everyone brings something unique. A community member might bring something about their own lived experience, no less valuable than the methodologist or a statistician. We all bring our pieces. Honesty goes along with transparency, not exactly the same, but also really important. That we not only are honest, but we also have to have that transparency piece to make sure that people really understand and see what we're doing. The bi-directional benefit thing, I want to spend a minute on that, because I'm not talking about research incentives. That's not something that I'm including here and thinking about bi-directional benefit, although we do give participants research incentives that are important to compensate them for their time and their parking and their childcare. So those things are kind of separate. I also am not talking about necessarily the outcome of the research. So obviously there's a benefit there if people are more healthy. And that's also not what I'm talking about. There's other benefits to research as well. So on the researcher side, some of our benefits include getting grants, getting publications, and moving along in our success and professionally. We want to make sure that those benefits are also recognized, and that there is an equal benefit on the other side, depending on what whatever it is that those folks need. So if we're working with a population that maybe doesn't have access to health care, right, or access to other resources. It doesn't necessarily have to do specifically with the research. Like if you're studying diabetes, but you know that your population might really benefit from having access to services that don't have anything to do with diabetes. Maybe it's housing. That too is part of this relationship and can be and should be part of this relationship. Also, dialogue and listening, mutual learning, that's how we communicate with one another. And then my last slide, and I'll turn it over to my colleagues here, is just to point out that there is a continuum of community engagement. So you might, at the very kind of low involvement, there might be just informing the public of what you're doing, or consulting with a community group, for example, like a community advisory board. So you're talking to them about your recruitment materials or specific data collection or dissemination, like discrete kinds of parts of your research. There can be also more involvement where folks are contributing throughout the research project, back and forth. These issues, these last two, collaborate and empower, those are really much more decision-making powers for your partners. So if it's a community-based organization, how much are they informing how the research is conducted, how the research is designed, what are the research questions to begin with? And then also having that decision power and being part of the leadership of the research project. Okay, then I'm going to pass it off to Gina Green-Harris, who's going to talk a little bit more about bidirectional benefit, I think.
Thank you, Sue. Good afternoon, everyone, and thank you so much, Dr. Passmore, for giving us a great opening. I'm going to get my slides going. Sue said I am Gina Green-Harris. I got to get that right. There's a question that asks if anyone's a graduate of UW. I'm soon to be that, so we're working on that. So going to talk a little bit today about one of our programs, the Amazing Grace Chorus, which is out of our program, which is at the Wisconsin Alzheimer's Institute and the Center for Community Engagement Health Partnerships. And our purpose is about quality of life, social engagement, and support. So I'm going to talk about research in a different way. Wanted to start off by sharing with you guys a little bit about who our team is. Our staff is we're located in Milwaukee, Wisconsin, so we're off campus, but we are a part of the university. And so what we do is have a very diverse staff. It's really important to see that behind the scenes, all the people who are working in the office make a difference. And so I wanted to always share with you that you might see me presenting, but without these folks, the work would not get done. So we need to acknowledge that. Our office have we have 5 integrated mission areas. Today I'm going to talk a lot about community engagement, but we've got community and professional education. We've got service. I'm going to talk about our service delivery model with the Amazing Grace Chorus. And then we've got advocacy through our community advisory board, which I won't be talking about today, but Kat will be talking about that. And so we're going to talk a little bit about why that's important through Q&A. And then, of course, we have research. Many of you may not know, but we are part of the home of the Wisconsin Registry for Alzheimer's Prevention, also known as RAP. So we host the RAP program in the Milwaukee office as well. Our office is founded and based in the asset-based community development model and an outreach model that we developed when we started our office in 2008. 3 core principles. First one is community engagement. Notice it's not outreach, it is engagement. There is a difference between outreach and engagement. We can start off by outreach and where many of us are getting to know people. Engagement means bringing people to the table, inviting them, understanding who they are, and then having an authentic relationship where there's this bi-directional relationship that Dr. Passmore talked about. Then there's the involvement piece, meaning that the institution, the academic academic relationship, there is beyond just as what can I get from you, but I've got to come, sit, learn of the people, be with the people, involve myself on a Saturday afternoon or a Monday evening, beyond just that scope of surface things, but understanding what's important to the community and then building on that to develop program service model with them. And then finally, after we do that, we recognize the community as experts in the work that we're doing. Why? Because we have content knowledge. Most often the community has the best lived knowledge. And also, besides that, we have to recognize that while we believe what we think is true, when you get to the community, and I'm sure Dr. Phelps will talk about this, the community may have a completely different idea, concept, and then the language that we're using with the community is also going to be important. But then when you begin to value community in an authentic way, that's where commitment from the community comes. I often say, and we've said this since the beginning, our motto is meet the people where they are. But if we build it, they will come. If the community builds it, not only will they come, they will stay, and they will also be accountable to their own work. They will definitely make sure that they have part of that process, and it will be their ownership. Dr. Passmore talked about this continuum of engagement, so I won't stay on this long, but this is really where our work flows. It's an ebb and flow for us, and we really stay focused on those last two elements of collaboration and shared leadership. Truly using the asset-based model, it means that we look at what the community is identifying as important. We bring them in the early part of the conversation. They help us drive our work. Our community advisory board helps us drive our work, and then we have this shared governance, this shared leadership where decisions are made. I'll give you a quick example. As our community advisory board was starting, one of the questions was, why do we take so much blood for the RAP study? And clearly we brought that back to the PI. It was investigated and found that we could actually reduce the number of the amount of blood we were taking. A good example of how community and the relationship between the researchers can work and actually make a difference. Now I'm here today to talk about our service, which is the Amazing Grace Chorus. The Amazing Grace Chorus actually was started in 2014. It was a model that was built out of a research study. And Dr. Mary Middleman, who is out of New York University, had been working with patients and family caregivers. And the goal was to develop a program where caregivers could actually get support and actually understand how to better live with their persons who might be on the Alzheimer's journey, and quite frankly, to do so in a safe way. Well, in New York, and we're not from New York, we're Midwest, and we're Midwest nice, right? So in New York, there were caregivers and supporters, but they were coming on trains. They were coming from across New York in these very precarious ways. Well, the question was, could we create a a chorus in Milwaukee in an urban setting like the one that was being developed, that had been developed in New York, and make it work for our urban community, AKA our Black folk? So we said, yes, we can. We had received funding from Bader Philanthropies. Quite frankly, we took a trip to New York in 2014. We took our community advisory board chair. We took our team, and we went and visited and sat with them for 2 days. And when we came back, we absolutely knew we had to do this chorus. We created the Amazing Grace Chorus similar to the model in New York. The one thing we did not do, which really upset Dr. Middleman at first, but she understood, was we did not use it as a research program. What we agreed to do was to use it as a community engagement model, as a give back service to our community. Because we had done so much research, we wanted to show good effort, good faith. We wanted to bring the community along. We had just gotten to a place where we were helping our community understand dementia at that time. If you remember 2014, that was 10 years ago. It's not like it is today. But we had just gotten headway with the community. It was not a good idea to say, let's do research. That's one thing we have to think about as researchers. Is it the right time? And we'll talk a little bit about that. So the Amazing Grace Course became the service model that we created, where we bring a one-stop shop to families. They come, they sing, they make beautiful music, but they also have in-services. They are working with providers from all of the Alzheimer's agencies, the aging agencies, and community agencies, legal agencies. We bring that to them, and they begin to get information and questions answered. And then the beautiful part is, yes, they do come, they sing together. What we learned over 10 years ago is that this actually did improve caregiver. It reduced burden. It reduced the angst around having a loved one who you cannot take out in the community, right? Was how do you bring them in a healthy environment where the caregiver can get support, but also we learned the person who was living with dementia could also get support. And so as the community advisory, as the chorus grew, I don't know why the community advisory board is on my mind, probably because they're very integrated in this work as well. But what we also had this chorus to do is that they have 14 weeks of rehearsal, and then they started doing community concerts. Well, the first community concert that they did, we were expecting very few people. Well, we had overflow in the room, and it was 2 a year. Well, now you will know that they actually have concerts on a regular basis. They do, and the program we thought was going to be twice a year is ongoing. It has grown significantly. And so what you see in these pictures are actually, we were invited to come to St. John's on the Lake, which is a senior home, and we were doing a tribute to Dr. Martin Luther King Jr. The room was filled with folks. And what the coordinator said is, our people never come out to anything. They're coming out to your event. They were lively, they were active. But what was really important is that the community advisory board members were lit up. They were actually participating. They actually were growing, right? And so the families are ever grateful for what we're doing. When you look at these pictures, you see the smiles on their faces. You see the sunshine that they actually have. So this is really important. Then, as the time has grown, because we knew we wanted to continue this work, and thanks to COVID, we started live streaming. So not only do we do this chorus in person, but now those who are bound, who are homebound, actually have resources to come and do this work. So you might ask, well, Gina, all that's wonderful, but what happens next? Where's the research at? Here you go. For those of you who are wondering, yes, we do collect data. Yes, we understand that we had to get a plethora of data because though we did not start off as a research project, we understood we would go there. So what do we have? The results, and this is a little older data, but it's relevant, and I can give you more. But what we know is in that 14-week session, we saw improvement that was reported in self-esteem. We saw decreased perceptions of failure. We saw increased participation in physical activity, increased engagement in the community, activity separate from the chorus. They were still engaging, right? My mom's singing at home. My dad's doing wonderful. He's talking more. He's trying more. Improvements in communication between family members and home. And so we know that when we think about this amazing Grace Chorus, it started off as a community event and as a community program, but it has since moved into becoming research ready. And how do we know? Because the chorus has asked us, are we going to be able to do research? Now, I also want to say, as we've built this chorus, we've also been in coordination with the Wisconsin Registry for Alzheimer's Prevention, families have been joining the RAP study. So it actually is a way to collaborate and work together. And with that, I'm going to end there. But I wanted to share with you the Amazing Grace course. Our purpose, quality of life, is social engagement to support. With that, I'm going to bring our third speaker, Dr. Kat Phelps. Oh, Barb King's coming. Well, this is because Dr. Barb King is going to go over time. She's already told us. Just kidding. Thank you, Dr. King.
It's true. It's true. Thank you, soon to be Dr. Green Harris. So true. These people know me too well. So I'm going to talk about a little different group that I engage with. So Dr. Passmore had indicated that my community is organizations. So I engage with hospitals, and then I engage with inpatient units within hospitals, and then nursing staff within those inpatient units, and also patients within the inpatient units. So there's multiple levels of engagement that Dr. Stiege and I have the pleasure to work with in our Move-In project. So engaging with organizations can be a little bit different because you have to think about these structural components. And when we create interventions that are health systems related and organizational related, organizational redesigns, it's really critical that we get it right. Because if we don't get it right, it has long-standing ramifications for future research, and it could have implications on patient outcomes. So we have to really think about what level of workload am I asking this organization or the staff to take on with an intervention that I'm going to launch? Is the intervention a right fit for the organization? So if it's not the right fit, it's not really going to be that successful, and it could have an impact on organization outcomes. And the last thing I want to do is put more burden on a nursing staff that's already burdened. So it has to all connect. So when we engage hospitals and units and nursing staff, it's really important to think about what is their real world experiences, how do we think about working together in a design, and then what outcomes are really critically important, and most importantly, that when we exit that site, that we continue to support them in outcomes that they think are important or the organization thinks is important. So I'm going to tell you a little bit about my whole background. As anyone who knows me, when we talk about ambulation, I could go on for hours on this topic, so I'm going to summarize this very briefly. We have a process called a hospital-acquired disability. So that means an older adult enters a hospital functional in their ability to do activities of daily living and ambulate independently across the small room. Unfortunately, about 65% of older adults age 65 years or older are going to lose their ability to do one or more of those activities of daily living or lose their ability to walk independently. And we know, we have decades worth of data that says that limiting patient ambulation or enforcing bed rest is the primary predictor for this loss of ambulation ability. And we also know that about up to now, some data has shown 100% of the time, older adults will spend their time in bed during a hospitalization. So this loss of ambulation is associated with multiple negative outcomes and bad outcomes for clinical organizations. We see higher mortality rates in an older adult population. They have falls both during their hospital stay and then with the first 2 critical weeks once they get home, we see much higher rates. Patients are not happy when they come in independent and leave with a new disability they did not have before, or now they no longer can walk by themselves. We see much higher rates of new nursing home placements. Every older adult that I have ever talked to that said, please, I just want to go home. That's where they want to be. They really don't want to have to go to another organization. We certainly see increased length of stay, which impacts organizations, and we see higher readmission rates, which impacts organizations. So nurses have been identified as the healthcare provider that's responsible for maintaining patient functional independence. But we also know that nursing staff infrequently ambulate patients. We have tons of data that we've been able to document that. And our work with talking to nursing staff is they clearly can lay out, here are the multiple barriers that get in the way from us being able to do this. So they talk about there's problems with trying to figure out how do I get this into my workday. If there's high acuity level going on in the units, lots of admissions, lots of discharge, things get disrupted, ambulation goes away. The culture for mobility ambulation right now is we focus on mobility restriction instead of mobility promotion, primarily driven by our culture of fall prevention right now. And it's interesting that CMS just came out and said, oh, maybe we have a problem now because we're so focused on fall prevention that now we see restriction in ambulation. So we need to shift what's happening and the message we're sending out within organizations. Nurses say, I don't feel comfortable. I don't have the skill set I need to make that decision. Can this patient get up and ambulate? And can they walk? And can I walk them? And there's limited resources. People get pulled in multiple different directions. They have competing demands. They get pulled away from the patient's bedside. That affects their ability to get somebody walking. And lack of communication around, can this patient ambulate? How do they ambulate? When do they ambulate? Is it in the chart? Do I pass it verbally? Are there rapid means for us to think about getting this information? So Dr. Steege and I thought, all right, we should be able to figure out what to do. So we took our research and we thought about how do we map this onto a systems model, and we thought about how do we think about behavior change. So we integrated social cognitive theory, and we came up with this multidimensional intervention that consisted of 5 components. We knew we had to address training, we knew we had to address resources, we had to think about communication, we had to think about the whole ambulation environment, we had to address unit culture. Now, so this is what Movin' looks like, which is mobilizing older adults via systems-based intervention. We love our Movin' dude. We have this as a lapel pin that our staff wear. This is a registered trademark now. This outlines, these are what these components look like. Here's how we matched that up with what we thought about what these components would look like. But we did not design this in isolation. We had the research piece of it, then we had to bring it to our community group, which are nurses, and said, so we think this is what we're dealing with. Does this make sense to you? And then how would we operationalize this? That's another big peak. So we started building teams. So we launched this at 2 different organizations. We have partners, wonderful partners at UW Health, and we have wonderful partners with Aurora Healthcare System. And we started working with them on design for their site. Do these components make sense? How do we make this fit for your unit? Trying to keep the fidelity to the intervention itself. And then what do the outcomes need to look like? So we started with one group. Our original launch was our partners across the street, and they were so brave and so supportive of us to say, let's do this. Let's see, can we launch a multi-component intervention with 5 moving parts at the same time to see if it will work. And they said, we are on board. We will work with you to see if this will work. So that was our first engagement of what does the psychomotor skills training need to look like? Can we pull people off the unit? How many people can we pull off the unit? What does your communication need to look like? How do we think about ambulation measurement? So we really worked, they helped us think about where's the fit. Then we thought, all right, and we had great results, which you'll see. And then we thought, well, it's just us because we're so enthusiastic about this. So we needed to figure out, does this work someplace else? And can we create a roadmap so that other institutions could launch it? So we worked with multiple organizations, multiple different nurses to help us think about the roadmap creating. We came up with this implementation manual. So we laid it all out to say, can I hand you a manual? Will this work within your organizations, and where can you make changes? And what kind of outcomes will you have? So that was our first pulling it all together to make it work. Then we thought about what's our prepare, what's our implementation phase, and what's our sustainment phase. And we had to map that all out, which they helped us do. It does work. Every single time we launch this, it works. These are our very, very early results, which we're really excited about. You can see to the far left, here's the early intervention phase. We pulled away, stopped giving them gift cards and celebrations and pats on the back and announcements every week. And they just kept going. And it was now theirs. And they sustained it. And it fit for their organization. It fit for the unit. We said, okay, let's replicate it. Does it work? It worked again. And again, we worked with them to think about the fit, keeping the fidelity of the components, but does it fit? It worked again. We launched it again. It worked again. So we know we have something that makes sense to nurses. It gets at their barriers. They can implement it. They can sustain it. So I feel very strongly when I think about entering into an organization and community engagement that I just don't come in and say, help me with this, and now I'm going to back out and leave you and not provide anything back to you. Providing that back is really critically important. So we constantly thought about how do we support our organizations in their efforts, and what do they get out of this? So every time that we work with somebody, we think about how do we support you? Do you need to do presentations? How do you get these presentations out? Is it local? Is it regional? Is it national? And we're not the ones presenting. They are presenting their data their implementation of this program. We support them in the abstract. We support them in getting the data they need. We support them in helping them understand that. So 2 organizations that have done this have won awards for quality improvement through their organization. So that's, to me, that's the, that's the cream on top of the dessert there. It's like, I want to see them be celebrated. We want to see them be recognized for their efforts. And so now I'm going to turn this over to Kat Phelps.
What a great team to be on. Thank you, everyone. One of the things we think about at this amazing institution is something called the Wisconsin Idea. And one of the ways the Wisconsin Idea has been summarized is this idea that we blur the lines between what happens inside the university setting and the well-being activities and lives of people across the state. And oftentimes the way that's presented is moving the learning and expertise from within the institution out into the world. But what I'm going to talk about today is the other direction and how we pull in the expertise from people's lives, their needs, their interests, to energize what's happening on campus that can then completely continue in a loop that brings things out and also then brings things in. I'm a part of this team. It's the Wisconsin Network for Research Support. We're small and mighty. These are my colleagues, Kim and Mariana. And we work directly with 2 strong community groups out in Madison, Wisconsin. One's based with a community center called the Lucier Community Education Center, and the other with the Goodman Community Center. I'll talk a little bit more about these groups, but our big joy is that next year we will be celebrating the 15th anniversary of these groups being in operation. So they're strong and they're long-lived advisory groups. The work that both our university-based group and these community-based group does really comes at the intersection of health, equity, and community to amplify community voice in research. And specifically, we're focusing on centering the voices of people who have historically and unfortunately are still currently experiencing discrimination and health inequities. So we want to shrink the distance between the research and academic enterprise, and as I mentioned, that incredible lived experience and wisdom that lives outside of the academic walls. The term centering voices, I want to make sure we're all on the same page. This is a wonderful definition that was created a few years ago. It's about uplifting, trusting, and valuing the lived experiences of people most impacted by issues and inequities. So this work goes towards approaches where those that are most impacted are part of leading, identifying solutions, setting priorities, creating policy agendas, and shifting the narrative. Dr. Passmore earlier showed a model that had the layers of a circle, and just in case you think this might be a small following of people who think community should be at the center, I want to show this picture that was released by the National Academy of Medicine, and look where community is. Community engagement is square in the center of transforming systems to achieve health equity. There is a belief that we cannot do the work of shifting health disparities without the voices of the people who are experiencing disparities, and hearing and learning from that is what allows these other layers of transformation, which include partnerships, alliances, expanded knowledge, and then improved health and healthcare and programs, and finally thriving communities. It all stems from that listening and that learning. Community voices. So I want to talk about how our small team is a part of this work of listening and learning from lived experience. We have 2 ways in particular that we do that work. And one is to work with research teams who specifically want the experience of someone who has experienced specific to a condition or a group and a culture. So it might be, as in this case, Mai Chu Lor really wanted to work with the Hmong population. She was interested in how end-of-life conversations may be very different in a culturally responsive way for the Hmong people than it might be for the way it was developed for predominantly white populations. So she worked with students to connect with elders in the Hmong community to talk about end-of-life conversations and how that might be different in the Hmong community. We also worked in Milwaukee. This is a group that's working with smoking cessation in the African American community. And again, the driving force between even the first question of what is the problem? Not just, here's our solution, what do you think of it? But earlier, what is the problem? And what was really interesting is these folks were saying, we cannot talk about taking away cigarettes and smoking until we address the stressors that are the cause of us smoking. So just coming in to say, let's look at a program to remove smoking from your community is completely inappropriate when we're smoking because of all the other structural and systemic inequities that are causing us stress and leading to higher smoking rates to begin with. So this group was a part of developing an intervention that was, again, culturally responsive. Here's another group that helped to develop a conference. So this wasn't a specific research project, but as Gina mentioned, it's really important not just to do to support research for university faculty and staff, but to listen to the community and say, hey, what would you like to learn? Who would you like to talk with? How can we support a day that energizes your interests? So this group developed the first ever Wisconsin UW and U conference last spring that was completely designed by community members. And it was a one-day conference. Gina Green Harris was the kickoff keynote speaker there. And it really spoke to what can we do to support your interests in the community. The other group that you saw photos of at the beginning are called the Community Advisors on Research Design and Strategies. The acronym they use is the CARDS groups. I mentioned there's two groups and they're 15 years in the making. And I want to point out that this group is a really unique way to hear from community members without the time and energy it takes to develop a new group of advisors. Sue mentioned earlier that sustained relationships, honesty, transparency, trust are at the center of doing community engaged work well, and that takes a lot of time. So what happens is that our team puts in the continual time and care to foster, sustain, and grow those relationships. And then we invite people, come on into our group. We have this great group here. And we'll invite you as a guest to listen and learn and bring your specific research questions. And we'll make sure that how we're holding this amazing group is with care, with sustained interest, and with giving back and mutual benefits. So our group does that work and then invites anyone to come in and learn from them. And these groups have now, as I mentioned, been around for a long time. They meet with about 30 research teams a year. So nearly 3 times every month. And the range of the kinds of things they talk about goes all across the research spectrum. So instead of just being, hey, we've developed this intervention, what do you think? It's, hey, we're even thinking about addressing this topic. Does this topic make sense to you? Do you think this is important for the community? What elements of this topic should we focus in on? So topic selection and prioritization, and then when we're doing it, how can we do it well? How can we do it in a way that is respectful of your cultural interests and needs in your community? And then obviously getting it out. How can the reach and relevance be so broad that everyone's embraced, everyone's included in how it's getting into community. I want to mention two projects that were particularly interesting. One was in this early topic selection, a radiologist at UW was really concerned that the rate of breast cancer deaths was much higher in the African American community than in other racial and ethnic groups in Wisconsin in particular. And so he wanted to know about mammograms and what could be done to increase early mammograms. And he thought there would be financial barriers, he thought there would be location barriers, he thought there would be insurance barriers. And what he started hearing loud and clear was, we don't know about those rates and that risk for us, and the whole process scares us, and we need information and a buddy system where somebody who knows me, knows my community, is talking to me about it, helps me get there, and is a part of bringing energy around a culture change, not specific location, dollars, and money, a culture change. That was interesting information. Also, design and conduct of research. A researcher here in the School of Nursing was looking at how people change the process of conversations at points at which there needs to be surrogate care. So when somebody is not able to make care decisions in a hospital and families and loved ones are making them, how can doctors make those conversations the clearest and the most helpful for families at a very difficult time? And she gave some quotes of what doctors might say in those conversations. And one of the quotes had to do with, "I'm worried your loved one might not reach this capacity again." And what she heard was, "I don't want to hear a doctor say, 'I'm worried.'" And what she knew was, doctors and nurses are trained to say, "I'm worried," as a way of showing empathy. And yet, everyone said, "No, no, 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 no. Do not, as my doctor, say the words, 'I'm worried.' It triggers stress. It triggers, do you know what you're doing? Can I trust you?" What an interesting disconnect between academic training and what the community experience is. So listening and learning can have real-world consequences. What we know is there's lots of great thinking, experiences, and wisdom. It exists in our academic institutions, it exists outside, and the best that we can do is to keep that flow going both directions. Thank you so much for joining us today. We're going to take a few minutes to respond to some questions, and Meredith is going to help us by moderating that section. Here are our names and contact information. If anything we said sparked some specific interest and you'd like to reach out to us, please do. This is live. One at a time.
Okay. Oh, all right.
If you like, and that way there's less jockeying around once it's. I'll start with a question that was received in advance, and that is, how has increased misinformation about scientific findings and research and evidence, how has that impacted the desire for people to engage as community members in research and assisting in that regard?
Are you going?
No, you go first.
Okay.
Go second.
I think, oh my gosh, I don't have a really good answer for this. I don't know why I took the microphone. Except to say that I have been working a little bit with rural communities as the result of the COVID pandemic, and because of the COVID pandemic, and I think that there's a lot of misinformation that's been spread in those communities about research and health professionals and science. And I don't know. I don't know that there's a hesitancy, but there's also, I think, a little bit of a interest in being heard, because I think these voices aren't heard very often. And so, yeah, I don't know. I think that there's a balance there. I think if you're actually interested in hearing people's perspectives and their voices, including that, that it can work. You want to add?
I guess I can say a few things. It's a very, well, I'm supposed to look at you, but there is, I think from my perspective, I think in our community, there's not only are we, dealing with the mistrust of the past, but as Sue presented, it's still here. Can you see me now? All right, how's that? Okay, sorry about that. Okay, great. So I just want to say, I think, quite frankly, from our community perspective, there's always this mistrust. There's a wealth of misinformation. I think Dr. Google has contributed a little bit to that as well. And what we've been able to do, I think, as Sue was saying, we're in the community more, and we're trying to counteract that by just being present and actually sharing accurate information with community. And I think giving voice to community to share their concerns, where we are experiencing community when they find out truth, they're willing to actually still participate in the research. I think that voice, having that space to give voice is really critical, but I also think we have to acknowledge the misinformation, because what's usually misinformation has a mix of truth. And so I think we have to honor that and say, here's what's correct, and here's what's not correct. And a great example of that, we often talk about Tuskegee. Sue talked about that earlier. Well, in Tuskegee, there's a misbelief in the community that people were given syphilis. Well, that's the Guatemala study, right? So we can correct that. And once we start being transparent and actually owning what happened, but then giving the truth and allowing community to have space to have that conversation, I think we can experience change. Others?
Yeah, from an organizational perspective, it's not so much misinformation, but an information delivery, especially when I come in and say, this is a great idea, and the nursing staff maybe see, that's great, but the workload could look like this for me. So it's really talking and being honest and transparent about, will there be an increase, and if so, how much of an increase there will be.
I also think we can't overestimate the importance of having a pipeline of workforce that looks like, connects with, and is deeply rooted to underrepresented communities. Hearing somebody who doesn't look like me tell me their truth is a very different experience than someone who's a minister in my community is saying this, someone who is, great aunt saying this. So we need, as a broad academic group, to really prioritize making certain that we are inclusive in recruitment and retention of faculty, staff, researchers who are from minoritized communities.
Kat, you gave a really nice kind of a recap in your presentation where you spoke to partnerships, alliances, expanded knowledge, improving healthcare systems, and that sort of culminating in thriving communities. And it got to a question that I think is important for us all to be able to hear in multiple ways. Would any or some of you want to speak to, if you had somebody listening that couldn't quite connect that dot between inclusive research, engagement, inclusion, the types of research, and then ultimately getting to those thriving communities? Can you just sort of reiterate that? How does inclusive research equate to thriving communities?
I'm going to take it from an organizational standpoint. If I can include critical access hospitals in my organizations, it's critically important, because you know where we go? We go to the large community hospitals. We go to the large university-based hospitals. So our critical access hospitals are dealing with the same issues as everybody else. So when I don't include them and think about, does this intervention we create fit within that system, I'm not really improving outcomes for all patients, just for the ones that live in the big city.
And by that same token, if we don't include people who are experiencing health disparities, as we often don't, in research for any number of reasons, that means that we are working towards positive health outcomes for some, but not for all. So, I mean, we're not working towards thriving communities in that way.
You look like you want me.
I know. I feel like I had something else to say about that, but I can't remember what it was. I'm like hoping that you're gonna remind me.
Did I?
Yeah.
Did I remind you?
No.
I'm going to say this because I think this is an excellent question. One of the things that I think also is we're using the word thriving. And I think we have to be clear about definitions and language and what does that really mean? Because oftentimes you have people who believe that they are doing exactly what Kat described in her presentation. But I think it's really just as we have created these shared definitions, we need to consistently say, what does thriving community really look like? And not from our vantage point, but from the community vantage point, which I think that, for me, was the takeaway in Kat's conversation. It's really going to the nitty gritty of where the rubber meets the road, which is the community, and saying to them, we believe we're doing something that's going to help you thrive. Is this what you're thinking? Does it look like what you believe to be true?
And again, building on what Gina just said, translational science moves science from bench science inside a lab to a clinic, clinical outcomes, and then out to the community. And if you think you can get from clinical and knowing a clinic setting and have it fit to a community without being deeply rooted in the community, knowing that community, and having experience in that community, just makes no sense. You need that knowledge to make that work. So if you're really vested in translating into the community, of course you need the community's perspective.
Yeah, thanks for a great discussion. I'm wondering if you could speak to how do we better prepare researchers to not just value, but have skill and flexibility, as was pointed out during the presentations, in really valuing and responding to input from different involved, impacted groups with their wisdom.
Oh. Yeah, I think that's a very good point. There is, we train scientists in how to do data collection and analysis, and we don't train researchers in how to engage or talk to people, which is crazy because we involve people in our research. One of the things that we're doing, and hopefully at some point this will be part of every researcher's basic training, I hope, but in the meantime, we are involved in a research educational program to try to provide those skills for researchers and research staff called Just Research. And we have been operating since 2022. And before that, we did something called the Building Trust Initiative that did the same sort of thing. So we're actively working to do that. And hopefully we're starting to see some really good outcomes that are associated with people gaining skills and feeling like they've gained skills. Do you want to say anything about that?
So I think as Sue said, we've been working together for a long time. But I think building those skills is really important. But I think also providing a space for, researchers to say, I don't know. There's this high bar, as Sue said, we're trained on all of the content. We're trained on all of the clinical. But we're not trained on, quite frankly, the human practice of working with humans. And I think that it's okay to say, I really just don't know. And also acknowledging that because I may not come from that space, that community, I don't have that background, I don't quite know how to interact. Well, let's not ding people for that. Let's say we respect that and let's build from there. And I think those are things, giving people the space and the safe space, right? Which is what I think we do with Just Research. We give that space to to say that we basically say, yes, we understand. Let's work together to do it. Thank you.
Okay.
Okay. Thank you so much. We're at time. You want to thank
Okay.
people?
Thank you, everyone.
Thank you.
We appreciate it. Thank you. Does time mean we're like off camera?
I think so. Wait a minute.
Now,
You're right. This is wonderful.